Welcome to the Critical Care Obstetrics podcast. I'm Dr. Stephanie Martin, a maternal fetal medicine specialist and medical director at Clinical Concepts in Obstetrics. And I'm here with my partner, Dr. Suzanne McMurtry-Baird, nursing director at Clinical Concepts in Obstetrics. And we're continuing our conversation about when a mother dies, supporting family and care providers through this process. Before we get started, a couple things. First, if you haven't listened to our part one of the series, I strongly recommend that you go back and listen to that. We have a case that we go through and we kind of introduce some of the key concepts and support around and issues around what happens after a mother dies. And we want to thank you guys for really listening and supporting us through this, because this is such an important topic, but it's very, very heavy. And you know, there is no good outcome when this happens. So we really appreciate you guys being interested and wanting to know more about this topic and being part of this journey with us. Before we dive into more of the actual presentation, you can watch us on YouTube. We do have slides for this. If you're listening and you want to watch it, you can go to YouTube. Just look for Critical Care Obstetrics Podcast at YouTube. Don't forget about the Critical Care Obstetrics Academy, where we have a library of online courses that we created specifically to help build your confidence and grow your skills in managing high-risk and critically ill obstetric patients. We're also on Patreon at patreon.com/CCOB. This is a great way for you guys to help support our mission and allow us to continue doing what we're doing. We have exclusive videos, interacting directly with us with webinars and Q&As and a lot more deeper teaching pearls and guidance. So with that, let's dive into part two. Go ahead, Suzanne.
Yeah, I think this part, you know, like you said, we had the case in the last part and we started the discussion about how to support the patient and family. But this is more focused on what do you do when this happens on the unit. And so it's more focused on those acute events and how to plan to get through that and some of the aspects that we've seen, not just in our experiences on the unit and in maternal deaths, but also we've seen some of these hopefully clinical pearls that we can share with you through simulation as well. We've seen some of the ways in which we've seen some resources, utilization, and processes that we wanted to help support healthcare providers.
I will say from my perspective, I think this has improved quite a bit in recent years. I think in general, there's a better understanding of vicarious trauma, PTSD, and, you know, just that healthcare providers are people too. And we experience these traumas in different ways than the family, of course, but we can't ignore it. I mean, I look back on most of the situations that I was involved in, and there was just literally no support at all. I was just on my own to try and figure it out, which meant I just stuffed it and got on with my day.
Yeah, or you had a close group of clinicians that you could rely on to support you.
Well, yes, but what would generally, because, you know, this is my generation too, you just moved on, like, and kept working and ridiculous hours. There were no work hour restrictions, and you just powered through and did what you had to do, and then it would catch up with you. Obviously, you would talk about your experience and get support, but not therapy, not in a directed kind of way, just in a, I need to debrief or download about this kind of way.
Right. Right. And I do think that we have more resources and more discussions about this now.
I tell the story, I don't know if I've told it on the podcast before, but I have a very distinct memory of I was an attending and there was a maternal death while I was not there overnight. And I came in the next morning and heard about the situation, of course. And I went immediately to the resident who was involved in the case. And the first thing I asked him was, "How are you?" And he just started crying. And I took him to a little secluded area so we could have a conversation, let him cry and get upset. And he said, You're the only one who's asked me that.
Wow.
In fact, the first response that he received was being chastised by his boss, the chairman, because he had not called someone in the chain of command in as timely a manner as the chairman would have liked him to, which was completely inappropriate. There's a time and a place to figure out, could things have been done better or not done better, but it's not immediately after the loss. Like, he literally got called into the chairman's office before the shift was over, right after the loss occurred. And I think, to me, my natural instinct was to ask, "How are you?" Not,
Yeah,
you know.
exactly.
And I don't know where that came from. It just did, but it stuck with me,
Wow.
and it has really fueled me to be very tuned in, I guess, as to how the team around me is doing, even when I'm completely tuned out to how I'm doing.
Yeah, and it doesn't even, I mean, and those words are so powerful, like, "How are you?" But I had the opposite experience of something happening, on a shift and involving a mom, and versus a nurse who just came up to me while I was sitting there, charting, and just kinda nudged me and gave me a cup of coffee. And she had made a fresh pot of coffee, 'cause, I'd stayed over, and it was, in the middle of the night. I wasn't on that shift. Normally, I'd been there all day, and now I'm all night, and she just kinda nudged me and gave me a cup of coffee, and I remember I drink my coffee black, and she had put cream and sugar in it, and I drank it anyway because I was like, "That was so nice." She was just supporting me, you know?
Yeah.
And
Yeah.
And I think that, again, we are talking about this, and I hope that we continue to talk more about how to support each other. It's important, especially in these events, because we talked last podcast about how it sticks with you. I mean, that coffee incident that happened years and years ago, but I remember it.
Mhm.
Those are the kinds of things you remember and you take and you hopefully pass on to somebody, to somebody else. But
Yeah.
anyway, well, let's get
Hopefully.
started. So the first thing that we've kind of put it into steps, step 1, 2, 3, and 4, and about how we can hopefully set up some systems and processes at your each institution, because we all have different resources, as we always discuss, but how we can not only see this coming sometimes, and to try to prevent it, and then once it's occurred, how do we respond? So a lot of this will have some systems and processes involved, but then how we support each other in the process. So we'll start with step 1. And step 1 is just kind of anticipating the events. We did a case last podcast about how the events should have been anticipated, but they weren't. Um, and that was because of the assessment that the physician and the nurse had been doing for
Or
several
not
shifts,
doing.
or not
Or
doing,
not doing.
right, for several shifts, right? And there were triggers that indicated this mother was compromised, she was critically ill, and they weren't acted on. And we just wanna say this should be everybody's step 1, because we should all have early warning criteria in place. And I think that when you have something bad happen, like severe maternal morbidity or a mother's death occur, I think one of the first things that as a clinician that we do is we look back and say, why didn't I anticipate that? Or what could I have done to have changed the outcome? And I think having that system in place with early warning criteria, if you have it in place, you can just say, check, we had that, we acted on it, we anticipated, and it goes to your healing process when you have those systems in place, because you've done everything to recognize and manage that patient in an appropriate manner. But where I think healthcare workers really struggle a lot of times is if you don't have those systems in place, and then you reflect back and you go, woulda, shoulda, coulda,
Mhm.
and you question your care. And
Mhm.
I think that that's step 1, is having those barriers removed that standardize your clinical practices and try to prevent these events.
Completely agree.
Because here's just an example that we have. Patient's in PACU. She's following a cesarean birth. She has a normal temp. Her blood pressure is 90/53 with a mean arterial pressure of 65. So we're right there on the cusp of being hypotensive.
Mm-hmm.
Her heart rate is 132. Her respiratory rate is 24. So we have several concerning early warning criteria right there in this one assessment.
Yeah, she's not hemodynamically stable.
No. And again, you may hear that normalization start to come in. Well, but she just is post-op and she had lost this much blood and she had, X, Y, and Z, but those are still abnormal. So we have to have a system and process in place where we react to the abnormal assessment, and that requires notification, bedside evaluation by the appropriate provider. So in this situation, it would include the obstetric surgeon and the anesthesiologist. Two brains are better than one also. And it can't just be the anesthesiologist because it may or may not have anything to do with the anesthesia, right? So notifying the obstetrician surgeon is very important. And then we would want to consider what other assessment parameters we need to evaluate in that situation. Step 2 is the event occurs. And again, this involves those systems and processes that we need to have in place, but we also need to be aware of those, and they need to be practiced as we preach through simulation. So that bedside assessment occurred in that step 1. An OB-RRT or a hospital-wide RRT is called. Either one, depending upon what the clinical situation is and what your resources are, and then possibly a code blue.
And I want to highlight here that we have step 1 and step 2. Some would argue that step 2 should be step 1. Well, step 1 is the, assessment, the triggers, the early warning stuff. Step 2 is the event itself. In our experience, most events are predictable.
Yes.
And can be seen coming on. It's very rare that it's actually a catastrophic instantaneous thing. Yes, that could happen. She could have a stroke that is from a ruptured berry aneurysm. She could have an amniotic fluid embolism. And even amniotic fluid embolism may have some warning criteria happening before the actual arrest. So we just are acknowledging that there are more often than you think opportunities to predict or at least understand that your patient is deteriorating before an acute event occurs. So step 1 is the recognition part of abnormalities happening, and then step 2 is the event itself.
Right. So this event has occurred, and really those roles should be clearly identified and delineated beforehand. But if not, here's some advice. And this, again, we've seen in clinical practice, but also in simulation. The charge nurse or the team lead really plays such a pivotal role during this time. The charge nurse really needs to be the one that is looking at the room. So Julie likes to talk about a nurse in charge of the room. A lot of times in a clinical unit, that is the charge nurse. And it's, again, depending upon where you work, that is the charge nurse. But you have to confirm that you have the appropriate number and the skill mix responding to the emergency. One of the things that's really prevalent during an OB code is that everybody shows up. It's unusual, right? And everybody shows up. And that is why we'd like to use those roles that we've identified, and to have those, even where you're standing around the bed, is so important to know what your role is. But that charge nurse is that team lead, just to make sure, do we have the right people here? Do we have the appropriate number and the skill mix to respond to this particular emergency? Once the appropriate team members are present, then the charge nurse usually returns to the unit for function of the unit. He or she is the airplane director. I think of the guys and the ladies that are out there in front of the plane saying, come this way, you go that way. They are the director of the unit functions, and they cannot be tied up in the middle of the emergency. Usually, you can't
Right. And
afford to remove them.
no, you can't. And I think this is a mistake that a lot of teams make, is that they use the charge nurse as an integral part of the resuscitation process itself instead of assigning other roles, because there's no rule that says you're not going to have another emergency on your unit. And you don't have 2 charge nurses on at a time most of the time. You typically have 1 available. So you're going to, that charge nurse is in charge and then is going to delegate responsibilities and roles based on what you've predetermined in your unit.
Right. Well, and the charge nurse is the only one that knows what else is going on the unit, right?
Right.
For every patient. They know if the
Yes.
ORs are
Yes.
open. They know the staffing of the unit. They know the other assignments that they've made for other clinical conditions that are going on simultaneously.
Mm-hmm.
So they have to not have that role of being chest compressor or medication nurse, if at all possible, in the middle of a code situation, because that allows for continued unit functions
Mm-hmm.
and other patients to be covered on the unit.
And we've been in facilities where, we were evaluating a facility once, and an OB code was called while we were on the unit. And what happened is the unit became empty, and other patients were literally abandoned because they hadn't assigned roles clearly to everybody. So everyone responded, leaving other patients inadequately covered.
Right.
That's dangerous. You can't do that. You've got to have roles assigned. And that includes the charge nurse not being an integral part. Yes, she's going to be one of the first responders in that situation, but she can't be relied upon to continue the process.
Right. And we saw it in simulation too when we were opening a hospital. We tested that scenario and everybody ran from labor and delivery, one unit, right? So the unit where you had Pitocin running on several other patients,
And MAG.
and people were just abandoned, immediate postpartum patients, depleted everybody. And it really made us sit down and say, okay, here is what your role is during an emergency and really think about it. So that's a little clinical tidbit. Stephanie, you want to talk about this form that we have for some of our teams that we work with?
We've created a lot of checklists that we'll hopefully have available for you guys in the near future. But this is about building a highly reliable response to OB emergencies, and it's just acknowledging all the different things that you need to take into considerations to make sure that your unit has a highly reliable response approach to any emergency that can happen, including what's your role delegation strategy, what team skills are you practicing at debriefing, and you can score yourself to determine kind of where you fit. This is also one of the free downloads that you get as part of the CCOB Academy. Now, I wanted to comment a little bit about step 3, if I can, Suzanne.
Yeah.
So you've had your events leading up to the event, and then step 2 is the event itself. And then step 3, you've got the actions that need to take immediately after the event has taken place. We've talked ad nauseum in other podcasts about how to handle the emergency, the event itself. But now the event is over. The patient's been resuscitated. The hemorrhage has been controlled. She has coded and been transferred to another unit. Whatever has happened, there are things that need to take place. Okay. And immediately post-event is primarily going to be task-oriented. You're going to be focusing on the paperwork, the documentation, the communications that need to take place, the immediate post-mortem care, the disposition of the patient if she's passed, et cetera. And if that's just a natural, immediate thing that needs to take place. But crucially, there needs to be a debrief. And this is not your typical debrief. This is a critical incident debrief. It needs to be interprofessional, and it needs to be facilitated by someone who is trained to conduct these debriefs that facilitate a safe environment where people can express their concerns, express their feelings in a safe, protected environment and talk about what went well and also talk about opportunities for improvement. But this is a very sensitive thing. And this is not just to be done by some well meaning person who knows how to do a simulation debrief. This is a different type of a debrief.
Right. Oftentimes, in larger institutions, a quality person will do these debriefs that have been trained in that role. Um, it's important that we do it soon after the event and include all of those that were involved in the care, which can be a logistical issue because, again, you're taking away a lot of clinicians out of the clinical environment to go into a safe place and discuss what happened. And again, this is an opportunity to immediately discover what went well and the opportunities for improvement.
Mhm.
But it should never be a finger pointing
Ever.
event.
And that's one of the reasons why it's so important that you have someone trained to guide
Right.
this debrief and that these things become part of your culture so that when events happen, the team's very comfortable that this is just part of the process.
Right. So when a mother dies, there's several resources that we want to point you to, especially through the AFE Foundation. You can find some of these support tools at afesupport.org. One of the tools that has been developed and available for you to download are quick tips for family members. Um, and you can see some of them on the site. And for those of you who are just listening, things like contacting immediate family members and loved ones, clergy, spiritual advisors who you may think may want to come to the hospital at that time, and obviously the sooner the better in that role for that tip. Number two, identify someone who will help share information to others. That's crucial. Um,
And by someone, we mean a family member. So these are tips for
right,
the family themselves,
right,
like things to take into consideration.
right. Three, ask someone to help take care of other children or pets. Take pictures and videos of your baby, even if the patient is critically ill or deceased. That's something that we, again, consider when we have a newborn or fetal death. That's pretty well practiced on your units, but not so practiced when a mother dies. And we've heard time and time again from patients who have survived these critical events, but also from family members whose loved one did not survive, that these pictures and mementos and things of that nature are critical for their healing and for um, their memories, to have those memories of the mother holding the baby or whatever the clinical situation is, that time, that respectful time that they have together. They may take notes or audio recordings if allowed, and that's, again, hospital policy or whatever. If you don't have that information, you can get that quickly through the administrator, that is, house supervisor who's on charge. It's a good role for them to determine some of these. But again, look at some of these tools that are online at the AFE Foundation. They've got some amazing tools to support those family members who are going through a loss.
And all of this can be found at afesupport.org. And that includes support tools for caregivers as well, for healthcare team as well.
Right. Step four, charge team, and again, the charge RN and the team lead. Evaluate what's going on in your unit when this happens. So again, this is kind of a regroup at that time, and to say, okay, we've got these procedures coming in that are elective. Maybe we have three inductions of labor coming in, and those obviously need to be put on hold for right now. Maybe new admissions, those types of things. Whatever you can do to kind of clear the path for the clinicians, because this is going to be a traumatic event for them. You want to notify the chaplain or social work services, and hopefully they're notified when a code occurs, that they're part of that team that come to help facilitate the path. not just for the family, but for the clinicians as well, and for visitors. We talked about that in the last episode of families being staying at the bedside when a patient codes. That there's some positive research for that staff allowing them to stay in the room, and that outcomes are not, you know, any worse when the patient's family is staying there. So, but having somebody assigned to that family, it may be a chaplain, it may be a social worker, and if the family chooses to stay. Limit visitors in the hallways. This is not a time when you want the hallways full of visitors. You want to close the doors of the other patients. This can be traumatizing, and I've got a story about that, and ensure privacy for the family. I remember one time I went into an emergency department and it was for something minor, and I had to get some x-rays, but I went in and I actually saw a patient in the room next to me as I walked by. And, the walls are not great in hospitals sometimes. They're not, this was kind of thin walls. And I could hear the patient talking to the nurse at different times. And I'm sitting there waiting for my x ray results to come back. And all of a sudden, I see people running and I hear alarms going off. And I see somebody bring the code cart down. And I knew exactly what was happening because we've practiced it with many, many teams, but been involved with it myself. And I knew that patient that had been sitting up in the bed talking when I walked in an hour before was coding, and he died. I knew what was going on because the curtains were open, the door was open, I could hear what was going on. And so after this was over and after the patient had passed, my nurse came in and I said, "Are you okay?" And she just burst into tears. This is an emergency room. And that's important, especially if you're talking about a mother who has died. People on the other patients on the unit know and hear
Yeah.
things and they know what's going on. So having family members and visitors out of the hallway and closing the doors, ensuring the privacy of not only those patients, but also the patient that is undergoing the code. So important.
I had a situation where I had a patient that had passed, and on labor and delivery, and it was an amniotic fluid embolism. And you're absolutely right. It makes it around the unit, and so of course I still have to go to work. So I'm making rounds that next morning on all the labor and delivery patients, and I walk into this patient's room who I knew. I'd been rounding on her for a while, and first thing she says to me is, "Am I gonna die of an amniotic fluid embolism?" And I, pretty confidently told her, "No." I had no business saying no. I didn't know what was gonna happen to her, but I thought the odds were pretty darn slim that I was gonna have 2 patients with an amniotic fluid embolism on the same day.
Yeah.
I mean, but she literally hit me with that as I walked in the door, and I thought, "Oh my gosh, like, she doesn't need me waffling, she just needs me to be confident, and yes, you're gonna be fine. I'm not worried about you."
Well, because they do, you need to reassure those
Mhm.
other patients and families, if
Mhm.
they ask about the emergency. So
Mhm. And
this
she
is
wasn't even immediately adjacent to where the emergency happened. This was a
yes,
big unit with probably 25 labor and delivery beds, so it had, like, 2 wings,
yeah.
and she was on a separate wing, and, yeah, they all knew.
Well, and the waiting room can be a real source of information for them as well.
Well, yeah.
So, other things to consider for the charge nurse or team lead is to designate a safe room for the debrief. We talked about that. Align support staff to assist those involved in the care. So,
You mean
it,
assign them?
assign them. Yeah. I say align.
Uh-huh.
Assign. So, this is also really important when a mother dies, or codes even, just have that runner. Doesn't have to be an RN to go run, get blood, for instance.
Mhm. Mhm.
But just as important is cleanup.
Mhm. You
And
don't want the people who are directly involved in the care having to deal with cleanup.
no, but also to consider those who are cleaning up.
Mhm.
I remember one of the last codes that I participated in was such a massive hemorrhage. There were bloody footprints going down the hall where people had run in and out of the OR.
Sure.
That was so massive. And I don't think anybody ever considered the cleanup crew that did go in to that OR, that what trauma they must have thought about. So that could be a charge nurse role to really give them the support that they need as well. Um, Next, evaluate the staff member's ability to return to work and assume care of another patient.
Hmm. That's big. I never experienced that.
Yeah, I have. I've experienced it as a charge nurse and as a nurse who had taken care of a patient who died. It wasn't like I got to go home.
Yeah, I wonder how different that is from nursing and physicians, because presumably the pool of nurses to step in and pick up a shift or slack or patient care responsibilities or whatever is deeper than for the physician, and there's
Right.
less flexibility um, to just say I can't do this today.
Yeah, I've done that one time where I had lost a patient. It was a
Mm,
newborn unexpectedly, um, and I had to go home. I had just lost a baby myself, and I just couldn't do it. But eh, I fortunately had a charge nurse, a manager that said, "Just go home," and they covered the rest of my shift. But that I think that's the key part of the charge nurse is to evaluate whether that nurse or physician can go back to work, you know?
yeah, it's an interesting thing because um, as I got real good at compartmentalizing
Yeah,
and just moving on and doing what needed to be done, and never even I wouldn't have even taken anybody's offer to go home. I would have just powered through. That's just how I was, and I don't think that that's necessarily a good thing. It just is fact. It's the way it
yeah.
was.
Well, I
So,
did that too until I had lost my own child, and then having that next one, it was really difficult for
mm,
me to stay in that environment for that shift.
of course.
So, I think it just depends on where that nurse or physician is, and again, I remember that last maternal death that I was on, I remember the attending physician saying, "Suzanne, you take the nurses and I'm gonna take the physicians, and I'm gonna see how they're doing,"
Mm,
you know? And I think it's a
mhm,
critical role being that
mhm.
lead.
I agree. I just think the physician role in that I think the nurses are gonna be more likely to be asked, "Are you okay to stay? Do we need to replace you?" or insist you need to go home. I'm curious. I'm curious what you guys listening experience. Is there a difference between when there's a bad outcome or a loss on the unit? Are physicians and nurses supported differently? What's your experience with it? I wonder.
Yeah. I don't know that there's any difference human
No
emotion-wise,
difference humanly in
right?
completely agree. What I'm getting at
I
is,
know. I know what you're getting at, but
yeah, like there wasn't. Maybe it was self-imposed, but and maybe it's generational. I don't know, but it wasn't okay to not be okay as a physician.
and I wonder if it was also a generational thing too, like, is that
Yeah.
still current, you know? Because I
For the
remember
record, we're Gen X.
I'm a boomer, so
Well, we're a boomer and Gen X.
yeah, I'm older than her, but yeah, I mean, I remember the days when residents they couldn't call in sick, right?
Oh, I lived those days, 100%. There wasn't you didn't call in sick. There was no such thing.
We would start IVs on resident physicians. They would be like ill and taking care of patients. They didn't have an
Yeah,
option.
it's completely different culture than it
Yeah,
is now.
hopefully it's not that way.
Yeah.
Okay, next thing to do and consider is confirm that a risk management report has been completed prior to leaving work.
Yes.
Factual,
Mhm.
objective, and then consider future assignments for the staff involved in the care. And I think
Mhm.
that's important. So when they do return to work, you know, maybe it's not the highest risk patient or
Mhm. And I think the documentation around all of this and the risk management aspect of it is
yeah,
is real, okay?
yeah,
You can assume that when a pregnant woman dies, that there is a very high likelihood that a suit will be filed, or at least investigated. So keep your documentation straightforward, factual, timely, and
Complete.
complete, no finger pointing, no subjective impressions, just factual. We've got lots of conversations about that. We talk about that more in our Patreon. But yes, be mindful, but don't be defensive.
Right. Nurse administrator or physician administrator lead assist the charge nurse to determine the need for additional staffing to resume care needs on the unit. That's huge. Again, staff may or may not be able to do the documentation and start taking care of another patient. Again, the documentation's tremendous. You're going to need additional staff. The administrator could check in with other staff members involved with the emergency and to make sure that their needs are met, not just the immediate ones that were involved, but other staff. Communicate what went well during the event and compliment the providers when that is
When appropriate.
appropriate. Right. I couldn't get that out of my mouth quick enough. But most of the time we do things well. Anticipate schedule changes as needed for staff time off. And this is huge because I've seen nurses and physicians require therapy after a maternal death and weeks off before they could return to work. And this is traumatizing for staff as well. And that administrator may also be the one who's been trained to lead that debrief session after the event.
And if they're not, they're going to make sure that the debriefing takes place in the proper manner.
Right. And then other considerations, checklist. You've heard lots
especially in a time of trauma.
Yes. To have responsibilities and, staff self-care checklist and community resources and counselors. These are all critical considerations to think about with a maternal death. You want to take this one, Stephanie? I know you talked with this at Grand Rounds not too long ago.
Yeah. A publication came out a few years ago on the medical pause, basically, which is about taking a moment after a patient has passed in a healthcare setting to just kind of acknowledge the significance of the event that just took place. Because very often, as I alluded to before, we become very task-oriented. And this is a trauma that your brain and your body are figuring out how to integrate and rewire. And it's just a reset. It's just a pause. It doesn't fix things. It's just an acknowledgement. And really it's a moment of silence to acknowledge the individual and the situation and to honor that person. It is non-denominational. It crosses all cultures. It's simply a time to feel and acknowledge. It's not supposed to intimidate or blame. It's supposed to make people feel empowered. It's very simple and very complex all at the same time. We're going to have all of the references available in the show notes. You guys can access this. There's tools on this available to you with a little a statement that you can use to guide what you say in this time. Again, this is not a religious process. Some may choose to make it so internally, but this pause itself is not a prayer, it is non-denominational. It is a silent acknowledgement, guided acknowledgement of the person that's passed and the situation the event that has occurred.
Yeah, I remember reading on this, and I thought it was very powerful and very moving.
Yeah.
I was very moved by this study.
Very powerful, very important. I think a version of this, it's not the medical pause, but a version of this, I think many of us are familiar with the honor walk, where when someone passes, and this may be your patient because our patients are very often organ donor candidates because they're young and typically otherwise healthy. And when a patient chooses to donate her organs after passing, then very often there's an honor walk in the facility as she's escorted to the operating room, to acknowledge the gravity and the significance of what's taking place. It's a
Right.
very important ritual.
Yeah, I can't see those without tearing up myself. I
Mm.
just think it's such an important component of caring, not just for the patient, but for yourself and for the honoring those patients that we've lost. So
Very
here's our
impactful.
oh,
Very
yes. I
impactful.
mean,
Yeah.
just even seeing a picture of it just makes
Mm.
me pause. So
Mm.
so some of our take homes, pause, check it out, figure out what's going on, be present, be human, be empathetic, listen, acknowledge, share resources, which we would love to hear about some of the resources that you've used in this scenario. Have an organizational plan and have that plan practiced so that you feel confident and you feel prepared on what to do when a mother dies. And then don't forget that you need support too. This is traumatizing for all of all of us, all clinicians, to have a maternal death.
So thanks everybody for being part of the podcast family, and especially sticking with us on some of these heavier topics. They're just as important as all the other stuff in our opinion, but we want to hear your opinions. We want to hear your stories and thoughts. So please feel free to share. You can get more of what we have to offer and continue to support our mission at our Patreon on patreon.com/CCOB. Don't forget about our CCOB Academy. You can find it clinicalconceptsinob.com, and with more resources to help you learn and grow as a provider of high-risk and critical care obstetrics. You can find us on YouTube and all of our other social media channels, and stay connected and tell us what you think. Thanks.
Thank you so much.